greater than inflation. We'll talk about the basics of Medicare, what Medicare is, what it's designed to do, and then we'll kind of get into a little bit more of the different, parts to Medicare. As I mentioned, I call this the alphabet soup of Medicare, and you have Part A, Part B, Part C, and Part D, and we'll go into what all these different parts are. And then kind of at the end, we'll kind of talk about this idea of filling the gap, is that once you kind of, look at and identify potentially what your healthcare costs in retirement look like, what are some different investment strategies and cash flow management strategies you can implement to be able to tackle these costs, in retirement. This slide refers to, a study done by, AARP, the American Association of Retired People, and, we've heard these statistics over and over again, especially around the baby boomer population, that, over 8,000 people a day will turn 65 starting in 2011, and it's going to continue for 18 years. By 2030, twice as many people in the U.S. will be over the age of 65 than today. And really the scariest statistic, if you look at the last year and the last couple of years, is the fact that healthcare costs have dramatically outpaced inflation. For the last 5-10 years, we've had relatively low inflation, built into the economy, yet healthcare costs continue to significantly increase, and that's why we're seeing that healthcare costs, probably on top of outliving their assets, is probably one of the major concerns for retirees and pre-retirees as they go forward. And really, healthcare planning in retirement has really been a largely unmet market, and how clients are going to take their assets and convert that into cash flow to be able to handle their healthcare costs in retirement, is really, really, important aspect of any retirement plan. So here's kind of the statistic where we talk about healthcare costs versus inflation. The cost of healthcare services is expected to rise. It rose about 7% in 2013, which is more than 3 times the projected rates for both inflation as well as economic growth. And we've seen this increase, this inflationary pressure in healthcare costs really for about the last 10 to 15 years. And there's nothing to say that we're not going to continue to see these increases over time, especially as we get into retirement. Healthcare costs are going to significantly increase over time, especially as retirees reach ages where they're going to need more healthcare services than they potentially would, within their working years. And here's was actually a statistic done by AARP that, 45% believe in their lifetime, that it's much more likely to see discovery of life on other planets than implementation of affordable, retiree health care. What continue to happen is less and less companies are offering retiree health care. I do understand many of you have the fortunate benefit of being able to access retiree health care as employees of the federal government. So whether you have that or not, it's a very important factor into your picture for being able to handle, retiree health care costs. So when you look at Medicare, Medicare is a federal health insurance program designed to help U.S. citizens age 65 and over pay for basic medical care in retirement. And that's a really important definition there, because Medicare was never designed to be the sole source of retiree health care in retirement. That it is the concept that the retiree is expected to absorb a significant portion of this expense. Very similar to Social Security. Social Security was never designed to be a retiree's sole source of income in retirement, similar to Medicare. And in fact, when you look at the way Medicare is designed, for the average retiree, Medicare is supposed to cover about 59% of their health care costs in retirement. If you look at the typical employee-based retirement plan, so the retirement plans that we may have while we're still working, the typical, private sector retirement plan generally covers about 70% of the health care costs, for its employees, with the employee essentially covering about 30%. So when you look at Medicare, one of the big myths out there is, Medicare is just going to cover the same exact things that my retirement plan did while I was working. And in fact, it's specifically designed to cover less than that. And I think that's a very important characteristic when you're looking at, well, how am I going to meet or how am I going to pay for those out-of-pocket expenses for healthcare expenses in retirement? We have to almost go into with the expectation is it's going to be more out-of-pocket in retirement than it is going to be, while I was working. Now, that's based on the assumption that you don't have retiree health care. And I think, given the fact that many of you do have the retiree health care through the federal government, that's an important consideration, into your plan, moving forward. So when you look at kind of the basics around Medicare, Medicare was signed into law back in 1965 by President Johnson. The first person ever enrolled was former President Harry Truman. And back in 1965, the premiums for Part B, which we'll get to in a little bit, was a relatively low $3 per month. And when they refer to original Medicare, it's really the combination of both hospital and doctor insurance, which you'll see as we talk to as Part A and Part B together. Another very significant act in the history of, okay, I just lost my, okay, another significant, Neil, I know we're recording it, but somehow I just lost the screen.
Okay. I think you got it back?
Yeah, I got it back. So another significant impact is what was called the Medicare Modernization Act that came down about 11 years ago. And really the main component with this was building a prescription drug component, into the Medicare system. So let's take a look at what, the different parts of Medicare are going to be. So as I mentioned, what's often referred to as traditional Medicare is the combination of Medicare Part A and Medicare Part B. And Medicare Part A is really synonymous with insurance coverage for expenses related or care related to being hospitalized. So it's generally going to look at inpatient care in hospitals. It includes, critical access hospitals, rehab facilities. Yeah?
Give me 1 second before you go on. I just had someone give me a text that said that they couldn't see the screen. Can everyone see the screen right now? Does everyone see the presentation?
Neil, this is Patrick. I see it.
Okay, so you see the presentation. Good.
Hi, it's Helen. I can see it.
Okay, so everyone can see it. We're on Medicare Part A?
Yep.
Okay, that's what I thought. Okay, maybe someone is just having difficulty. That's okay. Thank you, guys.
Thank you.
Continue.
Sure. So when you look at Part A, really synonymous with care related to being in a hospital. It can also include hospice, sub-home health care services, et cetera. When you look at Part A, Part A for many folks is going to have no monthly premium associated to it. Generally speaking, if you're eligible for Social Security, you're going to be eligible immediately for Part A. So if you're paying into the Social Security system or what they often call FICA, you're going to be automatically eligible for Part A. If for whatever reason you're not eligible for Social Security or for Part A, you can buy into Part A if you don't qualify. Depending on how much history you have, those premiums can get as high as $450 per month. But most individuals that we see and retirees we talk to, they're going to have Part A with no what I'll call monthly premium that they would need to pay into it. So it's, when you enroll in Part A, there's generally not going to be a monthly out-of-pocket expense, related to that. Now, the second part of traditional Medicare is what is called Part B, and Part B is really synonymous with coverage for going to see a doctor. Now, Part B is different than Part A in that Part B generally only covers about 80% of the covered costs after the deductible. You'll notice here that there's a chart that kind of shows you what your monthly premiums are going to be. And one of the big factors that a lot of retirees are facing that they didn't realize is starting back in 2010, what you're going to see is the premiums are going to be driven by your income, meaning that for higher income individuals in retirement, their premiums could escalate. So, for example, if you had, let's say, an individual who was filing for Medicare and they file their taxes jointly, they're a married couple, if their modified adjusted gross income is $170,000 or less, their monthly premiums would be $104.90. But what happens if somebody's income is greater than that $170,000 threshold? For example, let's take somebody whose income is $200,000. You'll notice here that their premiums are going to increase from that $104.90 up to that $146.90. So if you kind of do the math, it's about a 40% increase in the premium. This was put into effect as part of the Affordable Care Act, back in 2010. And effectively, what happens is higher income individuals will have to pay higher premiums for Part B coverage. Now, they're going to get the same exact coverage. The coverage itself, the medical coverage itself, doesn't change, but their premiums are going to be driven off of their income. So if you're an individual that's a higher income individual in retirement, your expectation is your modified adjusted gross income, if you're filing jointly, is more than $170,000 per year. You're going to have to factor in or be aware that your premiums could be significantly more. And also remember that Medicare is filed on an individual basis. So if we have a married couple, both age 65, and our joint income, let's say, is that $200,000 number, that would mean that the monthly premium for my Medicare coverage would be $146.90, and it would also be $146.90, for your spouse or your wife. So it is done on an individual basis. So these income thresholds can significantly drive up what those monthly premiums are going to be. Now, a lot of times people don't notice these monthly premiums, and the main reason for that is if you're collecting Social Security and you file for Medicare Part A and Part B, they're actually going to net your Part B premium out of your Social Security check. I remember talking to my father years ago, and he swore that he never paid any Part B premium. And he never paid any Part B premium because he didn't realize it was getting netted out of his Social Security check. So the important thing with Part B is you do need to enroll for both Part A and Part B. Part B is really designed to cover health care coverage and costs for seeing a doctor, but there is a monthly premium that's associated to that. And this is probably going to be one of the bigger decisions, especially for those individuals who are part of the federal employee health care benefit plan. Is do you want to pay, or does it make sense for you to enroll in Part B, pay the monthly premiums for the services that you're going to provide, because you're going to have both of those health care plans working at the same time. Now, the good news is with the federal employee health care benefit plan is it is what they call coordinated with Medicare, meaning that even though both plans are designed to cover very similar type of an expenses, the plans can work together and help provide you with actually even more coverage from that. But it is something on an individual basis that people would have to take a look at and even address. So when you look at, Part B premiums, it includes such things as doctor visits, outpatient hospital care, as well as some other health care costs. And you'll notice here on the bottom, we put the Medicare.gov /coverage, link. This will give you some idea of what exactly is covered, by Part B. So from an enrollment perspective is that if you're taking Social Security benefits, you're automatically enrolled in Part B, the first day of the month that you turn 65. Now, most people, the normal retirement age for Social Security is 66, might even be 67 for many of you. So if you're not receiving benefits, you do need to be aware of, either the initial enrollment period or the general enrollment period that would happen. The initial enrollment period, which is a very important date, really is the 7 months surrounding your 65th birthday. So you can start to enroll as early as 3 months before your 65th birthday, the actual month of your birthday, as well as 3 months after that. After that initial enrollment period, if you have not enrolled, there is a general enrollment period that lasts for the first 90 days of the year from January 1st through March 31st. One question that often does come up is what happens if I'm going to continue to work past the age of 65 and I'm still going to have my employer-based healthcare coverage as an active employee, they do give you a special enrollment period. So if somebody, for example, stopped working at the age of 67, they would essentially have 8 months to enroll once that employment, would end. And it is important to note that if you go to enroll in Part B at some point past your initial enrollment period, there could be a late enrollment period of a penalty of as much as 10%. Now, so Part A and Part B, if you combine them together, that really refers to traditional Medicare. You have your hospital insurance through Part A, you have your doctor insurance through Part B. About 25% of all retirees through Medicare are actually going with what is referred to as Part C, which is referred to as Medicare Advantage plans or private insurance options. So if you want to forego Part A and Part B and go the private insurance route, you do have the right to do that, what are often called Medicare Advantage plans. They generally can provide all of the Part A and Part B services. Some of the advantages of Medicare Advantage plans is they may offer extra coverage that's traditionally not covered, under Medicare, such things as vision, hearing, dental, or even other health and wellness programs. Now, what's typically going to happen is there is going to be an additional monthly premium in addition to the Part B premium. So the client has to weigh the benefits. Is the extra premium that I'm paying worth the value of the services that these private insurance options are going to be offered? Now, some of these private insurance options can also provide prescription drug coverage, which obviously is a very important component of the Medicare plans, moving forward. So it becomes is the incremental premium worth, the cost from that perspective? Now, what will typically happen is if you go the Part C route, Medicare will actually pay a fixed amount to cover, services, and then the individual is responsible for the other services. There's a lot of different options from these private insurance options. They look a lot like plans that you may see from an employer health care coverage perspective, such things as HMOs and PPOs and medical savings accounts and special needs plans. These plans are not offered by the government. They're offered by private insurance companies who have to comply with really the Medicare rules on different types of plans. So this is one of the core decisions that an individual does need to make is, do I go with traditional Medicare, which is kind of Part A and Part B, or do I go more of the private insurance route? The next part, or really the fourth part of Medicare that we wanted to talk about, is really your prescription drug coverage, which is often referred to is Part D. So your prescription drug coverage, you can get that through traditional Medicare or through Medicare Advantage plans. If you do it through traditional Medicare, the average premiums is somewhere in the neighborhood of about $35 to $45, per month when you look at the prescription drug costs. For those of you that may be, participants in the federal employees health care benefit plan, you probably need to combine, whether it's even worth it to do, kind of the Part D. But this prescription drug coverage has generated a lot of concern about how the plan potentially works. And this next slide is really meant to kind of illustrate how the prescription drug plan works within Medicare. What you do have with the prescription drug coverage plan is you have a yearly deductible. So in this example for 2014, Mrs. Smith in this example has an annual deductible of $310, which means the first $310 of prescription drug costs that she incurs in a given year is going to be an out-of-pocket expense for her. Once she hits that $310,000 deductible, we move into stage 2, which is kind of what I'll call is the normal coverage zone. And what happens in the normal coverage zone is she basically is going to have a copayment, and her plan basically share the cost of the prescription drug coverage. The way it works is really for the next $2,640 of prescription drug costs, Medicare is going to pay 75%, she's going to pay 25%. But once she gets to this combined cost of $2,850, that would be the $310 deductible that she's already paid, and then the sharing of the cost of the next $2,640, you get to what is called the coverage gap. And this is what has been affectionately known as the donut hole, because once you hit this coverage gap, effectively you don't have you have very limited coverage as it relates to Medicare. Effectively, the client will be, for the most part, on their own if you hit this coverage gap. And there's some things have been built into the Affordable Care Act to give discounts on both prescription drugs at the generic level as well as the non-generic level. But for all intents and purposes, there isn't coverage from Medicare. And you're in this coverage gap until, in this example, Mrs. Smith's total out-of-pocket expenditures basically reach $4,550. So if you do the math, it's for the next $3,600 worth of prescription drug coverage. Once she hits that $4,550 directly out of her pocket, then this catastrophic coverage kicks in, and where Medicare is going to cover 95% of the cost. But what's real concerning to retirees is this coverage gap or donut hole, that once I reach prescription drugs costs, north of $2,850, this is where I could have a major shock to my retirement plan, that I may have significant expenditures out of pocket that I would need to address for. Now, when you look at the federal employees healthcare benefit program, if you're part of that, they do have what I think is better prescription drug coverage than you do see with Medicare. So obviously factor in how that plan is going to cover you if you're lucky enough to be a participant, in that plan. The last thing we wanted to kind of talk about is this concept of Medigap or supplemental insurance policies. What you have with all these different components of Medicare is you do have deductibles, you have premiums, and you have other services that aren't covered by Medicare. So what you do have are what are called supplemental insurance companies that are sold by private insurance companies to help pay some of the health care costs that are not covered by Medicare. Now, this is only applicable if you're doing traditional Medicare. You do Part A and Part B together, potentially with Part D for the prescription drug coverage perspective. What you'll notice is that in most states, they will offer 10 different plans that are normally categorized by a letter of the alphabet between the letter A and the letter N. It is important to note if you're going to do a Medigap policy, and you're a married couple, you would want to have a Medigap policy for both spouses from that perspective. And they generally will tell you that the best time to buy a Medigap policy is the 7-month period in which you're 65 or older and enrolled in Part B. The reason being there is that if you apply for a Medigap policy right when you turn 65, you cannot be declined for a pre-existing condition. If you decide to apply at a time after 65, you can be denied or have your plan adjusted as it relates for a pre-existing condition. So generally, we recommend if you're going to do a Medigap policy, the best time to do it is right as you're enrolling, in Medicare. So when you look at kind of these expenses together, this is where they can start to, add up. And here's an example of potentially how your healthcare expenses in retirement could look like, especially if you don't have any sort of retiree healthcare. If you look at, those Part B premiums of $104.90 per month, if you amortize those out over 12 months, they could come somewhere in the neighborhood of about $1,385. You'll notice here there is a Part B deductible. It's relatively small, but it is a cost, that needs to be taken a look at of $162. In this example, we look at our Part D premium of about $30 per month for that prescription drug coverage. We built in $1,000 for additional dental, vision, and hearing. And in this example, although it seems a little bit high, you can see with this donut hole, where your out-of-pocket expenses for prescription drug coverage could reach that $3,600 relatively quickly. So when you start adding all these up, you can get to a pretty significant, out-of-pocket expense relatively quickly. In this example, we identified $6,500. Depending on your own individual situation, maybe you don't think your prescription drug coverage is going to be that high, but in this example, we didn't even factor in any cost as it relates to Part A. So we assumed in this example, this retiree didn't have any sort of stay inside of a hospital. It's important to note that, when you look at your Part A, just the deductible, we already talked about it not having a premium, but your deductible is somewhere in the neighborhood of about $1,200 to $1,300. So if you do have a hospital stay, that's another $1,300 that you could potentially, have to pay out. So when you come back to that idea that Medicare as a program is designed to cover a little bit less than 60% of your health care expenses, in retirement, you can see how these expenses could add up, pretty significantly. We didn't even, in this example, we didn't talk about somebody utilizing a Medigap policy. While that would absorb some of the premiums and deductibles, it would have its own premium, associated to that. And it's important to know when you look at this, if you're talking about a married couple, you want to look at these. Remember, you're going to have these expenses not only it's not at the couple level, it's for each, it's for each individual. So when you look at your Medicare choices, you really have to decide how and when and how you want to get your coverage. And the two basic decisions, if you're going to enroll in Medicare, is do I do original Medicare or do I go the private insurance route with a Medicare Advantage plan? So traditional Medicare is going to have your Part A, your Part B. You would need to enroll in both of those. Remember that Part B is the one that's going to have that monthly premium. And one of the things that's really important to take a look at is how, if you're a higher income individual in retirement, how is your income going to affect what those Part B premiums are going to be? So if you do go the original Medicare route, then you've got to make the decision, are you going to enroll in the prescription drug coverage program? And I think if you don't have retiree health care, the prescription drug coverage program makes a lot of sense. And then finally, that last step is, do I need a Medigap policy? Do I want to have that supplemental insurance policy to pay for such things as premiums, deductibles, and other services? If you go the Medicare Advantage route, it's really going to combine Part A, Part B, and Part D really into one plan for you. And it's probably going to look like an HMO or a PPO. As I mentioned earlier, about 25% of retirees who are enrolling in Medicare are choosing to go that Medicare Advantage plan, route. If you do join the Medicare Advantage plan, you do not need and actually can't be sold, a Medigap policy. In a little research that I did, if you are in the Federal Employee Health Care Benefit Program, there's no need for a Medigap policy. So that's another thing to kind of take into consideration, when you look at, your different options. So when you look at kind of your typical options, right, you have your employer-based health insurance coverage. I know a lot of you may have this as an option. That's a tremendous benefit. I know my father is a retired school teacher in the state of New York, and his health care benefit program is unbelievable in what he gets in coverage relating to having to pay that out of pocket. Some of you may not be as fortunate as having, that program associated to you. So the other idea is, are you going to pay for it, out of personal savings? And one of the options that we're starting to see a lot of retirees taking a look at really before they retire is, should I use a guaranteed income vehicle to create cash flow in retirement to pay my anticipated health care costs in retirement? And one of the things we see with a lot of the financial advisors that we work with is developing a income strategy to generate the cash flow off of their retirement assets to cover their anticipated health care expenses in retirement, whether that's $3,000 a year, $5,000 a year, whatever the situation may be, that there are investment vehicles out there that can help you address those cash flow needs that you're probably going to look at from a health care perspective in retirement. So we've gone through a lot of different, parts. I want to open up if there's any questions on anything that we've covered so far, or any questions out, related to Medicare that hopefully I can answer for you guys.
Laird, you there?
Yeah, I'm here.
Thank you for that. I appreciate the information. Are we going to open it up to Q&A now?
Yeah, that's fine.
Okay. Does anyone have a question they'd like to ask Laird?
This is Mike Permenter. I'd like to ask him a question. When you mentioned about a perhaps 10% penalty. Yep. What is that based on? 10% of the annual amount that you'd be paying if it was, say, $104, or is it 10% of 100?
Yeah, so if you look at, like, if the monthly premium is going to be $104, if you waited, let's say you delayed it 1 year, and then go to enroll in it, you could see your premium go from $104 to $114 approximately.
And then that would be for the rest of your life, 114.
Yeah, so it's locked. It's locked in. So you're gonna pay that. You're gonna pay that. That moving forward. Now, if you do have retiree health care, depending on the type of plan, you may not have those penalties if you have the plans that are coordinating. But yeah, so if sometimes you'll see the situation where somebody says, "Hey, I'm not going to do, the Medicare route." Sometimes you see retirees who will actually COBRA their insurance for a period of time, and then they decide 3 years later, you know what, I really should enroll in Medicare. There are some costs that they need to be aware of, and it is a lifetime cost. So whatever that penalty, would be, you're going to be paying for the rest of your life for that coverage. So, we recommend if you're going to be applying for Medicare at 65, or you think that's going to be your necessary health care, and coverage, it makes sense to have your ducks in a row at 65 so you can avoid that penalty.
Okay. I have another question, but I'll let other folks ask first, and then
Laird, following up on that question from Mike, is that penalty capped at 10%?
Yeah, it's 10% per year.
It doesn't get any worse than that?
No, it doesn't.
Okay.
Well, if you waited for 2 years, then you're talking about
20%.
20%. Okay.
Are there any other questions?
I have another one if nobody else has one. This is Mike Permenter again.
This is Patrick. I just had one question, Larry, in terms of, let's say your spouse is about 5 years older than you, and and they retire from the federal government, and they have, the health care coverage from the federal government, Blue Cross Blue Shield or something like that. And let's say, they're going to be turning 65 and you're 60. What's the process in terms of do she keep the medical coverage and so that I can be covered or something like that, or how does that work?
Yeah, I mean, you have to look. I think there's a couple of different variables that you would look. So obviously by her retiring, right, so she's going to move from the option of, being an employee in the system, and now you have retiree, health care coverage. Another option they could look at is, could they be carried on the younger spouse's plan, right? That would be one option potentially taking a look at. But to kind of address the other gentleman's question, if you do wait, then, you're probably looking at, some other, issues or penalties from that perspective. Then you probably, if they're going to be looking at, I think the Federal Employees Health Care Benefit Program as their primary, source, I think they've got to take a look at, do I also file for Part B? Is it going to be worth the extra premium for Part B for what I'm going to get, additionally within that plan? So I think that's probably, something you want to take a look at. I can tell you on, I went through and looked on the website for, the Federal Employees Healthcare Benefit Program, and they do have some pretty good documents that talk about the coordination between the two plans. If I have coverage within the federal employee plan, do I need Medicare coverage? And they talk about some of the different issues. I think at the end of the day, it's always going to be a personal decision based on the individual client's scenario, and it really probably boils down to is the incremental premiums for having both going to be worth it from a coverage perspective, moving forward.
Thank you.
Thank you.
This is Mike Permenter again. I have another question.
Sure, Mike.
I'm entering the phase where I'll be making a decision of choosing Medicare or not, and I've been trying to read different things, and basically it seems like it's a split decision there. Some folks suggest if you have a federal employee plan that you not join Medicare, and I know in the area where I live, which is in North Georgia, we're hearing that some doctors are now not taking Medicare patients. And so that's one of the things is there, what are those kinds of options that folks are facing there as far as choosing Medicare or not choosing Medicare?
Yeah, it's a great question, Mike, and I wish I had a universal answer that I could tell you, but I think one you have to take a look at is I do think one thing you want to take a look at is the coordination of benefits, and the plan, the federal employee plan could probably give you some more detail on how the benefits could potentially work. So, for example, the federal employee benefit plan may waive some of the co-payments or co-insurance and deductibles if there's services that are covered by Part B. So the plans can work together. There are some services potentially that could be covered by Part B that aren't covered or only partially covered by an existing plan, and some of the ones that they kind of identify as devices, either prosthetics or orthopedics or certain home health care or medical supplies. So you kind of have to balance whether you think that's going to be a factor, as it relates to that one. So I think, at the end of the day, at least at the premium level, you probably have to balance, okay, if I do the plans together, what's the incremental cost and what am I getting, from a coverage, perspective. Mike, I could be honest, I'm not that familiar with, doctors not accepting certain coverage. I mean, obviously, that's been some of the concerns with the, some of the things with the Affordable Care Act moving forward, and obviously that would be a huge factor for me is if I had, if my doctor would only accept one plan versus the other, that may be something that would drive that decision as well.
Okay, thank you.
Thank you.
Thanks, Mike. Does anybody else have any other further questions they'd like to ask Larry while we have them? Maybe take one or two more questions. Okay. It sounds like you fairly covered everything there, Larry. Thank you for taking the time to talk with us and our client base tonight. We will open this up to discussions. If anyone has any further questions, feel free to call our office, speak with me or GB. Larry, I appreciate the time you took tonight, and I will close down the conference call and wish everyone a good night.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thanks, Larry. Good night.